He serves on the Community Advisory Board for Substance Use and Addiction Medicine. He brings his own life experiences as a former substance user. His CAB, called Open Arms, is currently celebrating its 1-year anniversary, providing feedback to clinicians here at UCSF. A native of Orange County, he's lived here in San Francisco for over 16 years. His hobbies include video gaming, reading science fiction, and immature filmmaking. He loves living here and sees the potential for others to break free of addiction as he did. He's happy to be here on the panel today. We also have Tyrone Clifford on our panel, who is the manager of the Contingency Management Program, also the Stonewall Project at the San Francisco AIDS Foundation. He's been involved in contingency management for 12 years. And he also works on a program called PROP, which is a Positive Reinforcement Opportunities Project. And then we have one more panelist who might introduce himself today, if that's okay. Michael Ackerman, do you want to read?
That's me. Thank you so much for having us here today. To be honest, these are really accomplished folks, and I'm in the trenches every day. So I was a little nervous to provide a bio ahead of time. But I've been a harm reductionist for about 9 years. I work for the Stonewall Project, supporting, I keep the wheels on the bus. That's half my job. And the other half is I'm blessed enough to walk beside someone on their first step in asking for support, which is a really, really tough moment in their lives. And they've got to be really courageous about it. So I respect that. That's a little bit about me.
Thank you.
I'm a Bay Area native.
Excellent. Well, welcome to each of you. And again, thank you for being here today. So Jordana, we can get started with your talk if you'd like.
Yeah, I don't really have a prepared talk, but I will share a bit about the way we work with folks who use drugs, or as I like to think of them, just people in our research studies. Mm-hmm. So the only slides I have here, this one is of our field site, because I will probably refer to it frequently. But I think the most relevant study that we have going right now, it's wrapped up and we're analyzing the data. So it was called the POD study. It was the polysubstance use overdose study. One of the aims was to more standardize a definition of polysubstance use. You know, in the literature, it might be using more than one substance in a day, in a week, in 30 days. So this study was really unique because we used ecological momentary assessment, EMA. So the participants who were enrolled in the study would get pinged like 3 times a day with short surveys asking about what they had used, other things about their mood, and then more explicitly, like which substances had they used together in the same hour. So gosh, I guess that one is wrapping up, and I'm not sure where to go with that. But I can tell you a little bit about the field site and why it's important for this research. So as we were talking about, you know, working with people who use drugs, I think it's just like working with people. There is no difference. I was talking to one of the principal investigators. I work for Jennifer Thorvik and Megan Comfort, when I was talking to Megan and saying that I was really uncomfortable talking about the participants in our study as them, like defining them as people who use drugs, because that's not who they are. They are actually people. So I just want to be very clear and intentional about that. So what we do, I guess, from what I lead in this project, is we have folks come to the field site. We recruit them. I'm happy to answer questions about that process as well. They would come to the field site. The study lasts 1 month, and they come in for 5 visits. So it's really important, obviously, to start building a relationship at that first visit. I when I first started doing this kind of research about 2005, like right after I was born, I was taught that we were supposed to be very stoic and cold, and if we showed any emotion, we could bias the participants' responses. Even when you got one of those questions like, I'm not sure what that means, the response was, well, whatever it means to you. You know, that's not good data. So more importantly, if people are coming into this space and we want them to have a positive experience. So that first visit is pretty much when all the things take place, where we do the informed consent, your analysis to confirm their eligibility. They had to be adults who used opioids and another substance like a CNS depressant that increased risk of overdose. And then they would do a baseline interview with an interviewer. And then we would provide them with an older model iPhone that had the EMA app on it. And we would set up from what time the surveys would come in, and also do a little practice survey together. So traditionally, I think EMA is also thought of as a sampling technique, and the surveys may come out at random times or in response to geographical location. But given the folks that we work with, and many of them don't have Wi-Fi, and we purposely purchased phones that didn't have data plans to make them a little less valuable on the street, just in case. So, I'm sorry.
It's totally fine.
Yeah. So we've set them up on that. And then each week they come back to the field site and we upload the data. They do a check-in and we pay them. So it's one of the most important things is that we pay the participants for every single thing they do. Like, this is work. And we pay our participants with cash, because none of you would want to get your paycheck in a gift card. And because we use this participant-centered approach that's really rooted in harm reduction, I know there's disagreement on cash, but given the complexities of providing gift cards could cause, we went with this route. So I don't have any exciting results to share just yet, but we had great retention. If we just look at the number of people who completed the baseline and the post-interview, it was about 90%. We only lost about 12% of the phones, which I think would probably happen in any population. And yeah, we just funded to do an add-on study that is going to build on these findings. So the next part is we're doing a 2-year generative co-design process with collaborators. Folks who use drugs will be our partners in it, to develop a harm reduction app. And then the following 3 years will be a randomized control trial to test it.
How about the work you do with the house at lunch every week? Isn't that part of it? I mean,
Well,
sort of?
yeah. So, and the questions that were emailed, one of them was about strategy. And again, but the main strategy is just being kind and treating people with dignity and respect. But I was fortunate enough, because of COVID, we had to delay recruitment a little bit, but one of the PIs, Jennifer Lorbeck, suggested that I start volunteering as part of my work. I don't want to make it sound like too much, with with HEPAC at their fixed site on Fridays. So I have been doing that since 2021. Even though the study's over, I still do it because I love it. And it keeps, I get to keep in touch with my community, with the people that we worked with. And people get used to seeing my face and more than just this research setting. And then through that, I have met other really wonderful harm reductionists and have taken every opportunity to volunteer with them as well.
Thank you so much. Are there any questions for Jordana at this point? Anything at all?
Just curious about your retention strategy. Can you introduce yourself?
Oh, yes. I'm
Thanks.
Jacqueline Creel, a second year PhD student. Pronouns she, her. Anything else? I'm just curious what your retention approach was, because you had 90%.
So prior to the POD study, we had a longitudinal study. The original sample was 370 women in Alameda County that were on probation involved with the criminal legal system. And that study, it kept getting added on to as we were one of the sites for a 3-site study out of Kansas. So ultimately, when it was just our project, it was called Halo. They had a baseline, a 1 month, a 6 month, and a 12-month follow-up. And then on the months in between research activities, they are welcome to stop by the field site, and we pay them $10 just for popping in, confirming their phone numbers, or updating their phone number, and keeping in touch with us. So the POD study didn't really need that as much, since each of the visits that we did have those frequent contacts, and they were paid and people were motivated to come in. But I would say another retention strategy that I use is very gentle stalking. I tell folks that through the consent process, your participation is completely voluntary. We do have folks complete a locator form and provide some collaterals if they want to or have them, so that there are people we can call if we can't get in touch with them. And through that, we just, I just don't stop, I guess. So I think one of the main things that we do with the field site is maintain the same days and the same hours. So it's like that for years. We often talk about these populations as hard to reach. And I think of it more as the researchers, we are not reachable. So making ourselves available and making the field site more than a research space. And we will have snacks and water, a place to use the restroom. About half of the sample on any of the given studies that have been project directed for have been experiencing homelessness. So, it's impossible to find a restroom, and they could stop by the field site and say hello and chat. So I think the retention strategy is the frequent contacts, paying people, but also like building authentic relationships, getting to know them.
I can answer this one. My name is Mecca Yume, third-year student, PhD student, Hospital of Nursing. And my question is, considering that most of these participants are on probation, have you ever lost anyone to recidivity, like coming back to the jail system, and you're not able to get in contact with them anymore?
Yeah, so that happens on any study. So, and anytime folks can be arrested and detained. But depending on the way you've designed your research protocol, you may have permission from your IRB, and it may be part of the design that you could contact them to fill out a survey on paper while they're in custody. We don't do that. So as part of my gentle stalking, you can check, there's the Vine website, which is like the Victims Information Network. And then since, all of the folks I work with are in Alameda County, they're likely going to be in Santa Rita. So you can go on the Santa Rita inmate locator. So if I'm having trouble finding somebody, that's usually one of the last places I'll look to make sure I'm not going to be able to find them because they are not out there.
Hi, Jordana, I'm a Christian assistant professor in the Division of Substance Abuse and Addiction Medicine, or DSAM. Jordana, I know just from your help recruiting for some of my studies, that the participants in your study they seem really close to you, and they have a really genuine relationship with you. And you spoke a little bit about treating them like as humans, as people. And I guess I'm wondering, can you just speak about like what qualities within like research staff really facilitates this like trust and this closeness with our participants?
Well, I think most importantly, we don't think about trying to get people to trust us. In fact, I think most of the people we work with shouldn't trust me. I am a middle-aged white lady. That is dangerous, right? So we focus on proving that we are trustworthy. And we do that through the consistency where we are reliable. If there is a need and we can meet it within the boundaries of our IRB, we meet it. We are constantly working to remove barriers to make it easier for people to come see us. When COVID happened, we just moved the entire study to over the phone. And some incentives got mailed, some I drove directly to them. So I think with the research staff, the interviewers don't necessarily develop as close a relationship as I do, which I think is a good thing too. But I think part of that might be because of all the things that are disclosed in that interview, and there might be discomfort there. But in the situation that I'm in, the part I play at the field site, I just often let people talk. So when they're scheduling the next time they're going to come in, they might have had something wonderful happen the night before and they want to tell me about it. And I will listen because I care and I'm really eager to hear it. So I think that unfortunately those relationships are built like that because the people that I have the privilege of working with aren't listened to or heard or given that space in other settings.
I had a question about the harm reduction app. Are you able to talk a little bit more about what that is sort of designed to do? Like, is it focused on overdose in particular? Mm-hmm.
Yeah, it is. It will be. I actually can't talk about the content, not because it's proprietary, but because we are doing it in this co-design process, and we haven't started that yet. But maybe I'll come back next year and tell you all about it.
Yeah, thank you so much for coming and sharing the wonderful work that you're doing. And I think for a lot of the folks here, they're interested in the process that you described for co-design. What do you envision that looking like? Because it sounds like a wonderful way to, really partner with folks in a meaningful and intentional way. That you can just do a quick description.
Thank you. I have a lot to learn about co-design. It's part of why I've it also hasn't started yet, so we will hopefully have our first meeting in January. But because of these other studies that I mentioned, I think we've built some social capital with people in the community, and we have right now, I think we have 5 people and 2 harm reduction providers who are going to serve as our collaborators on this. There'll be, I think, 5 sessions, and these sessions will be iterative. So hopefully we will like have a product sort of put together, like to look at and see what we like by the second or third meeting. Also importantly, the folks that are participating as our collaborators in this are going to be paid like relative to what a researcher would be paid for doing the same exact work, because that's what they're doing. So, I mean, who better to inform a project like that than the people who would use it?
Any other questions? We've got about a minute or so left before we move on.
It's
We
great.
can always come back.
I ask you,
Yeah.
saying that part of your program, you pay your clients or participants with cash as opposed to gift cards. And part of my program is that we always use gift cards. So I'm trying to understand. Maybe we want to get more information about how has that been working for your program? How do you track the incentives that you give out?
So I know there's pros and cons to both sides, and I know especially if somebody is trying to quit using, that providing cash could be a trigger. And I'm assuming that's why your program might choose gift cards over cash.
It started as a research study long before I joined the program. So I'm not exactly sure the direct reasoning behind that, but that's not how I see it. Yeah, you can always trade a gift card.
Exactly.
It has value.
Great. Yeah, but not as much as cash. So that the way we do it is much like a petty cash account. So you know, we have the awarded money, and then I put in a request for a certain amount of money, and then I go to the bank, and they are really annoyed that I'm there because I ask for $4,000 in $10 bills, and we lock it up in the safe, and just keep a ledger with ID numbers and what gets paid out the same way you would with gift cards.
Is it, I have,
Sorry, what'd you say?
I said, let's start dropping some hints and make it next.
Yeah.
is it true that UCSF will not allow us to give cash anymore?
No, we do. I guess something.
It's
Yeah.
I started at UCLA and we were not allowed, this was in 2005, we were not allowed to give cash. They take away cards.
Good to know. It's something that's heard, so we've already, always we gave cash to people.
Yeah. My name is Marie, and your topic is my topic, basically, in Oakland or Richmond. That's why it started I'm a PhD student, second year, and I'm a nurse, I'm an emergency department nurse, and then I'm doing my research in harm reduction services and access, but mostly looking at the Black experience and the Latin experience, and to see cause I've seen that, and I show even though there's access and there's facilities and programs in certain communities, there's a decrease in the demographic, specifically for Black Latinx are going to the services. And I wanted to look at the comparison between San Francisco and Richmond and Oakland, which I know HEPAC is only going to Richmond, and they're the ones who provide most of the services in Oakland. But with the petty cash thing, I said cash for my IRB, my policy, because I believe in what you're saying. Who am I to tell them how they spend their money, where they go to spend their money? And then, but the study I'm doing my research residency in, they're also part of UCSF, they're doing petty cash too. And like, they're giving cash. This is like the same thing, like, who are we to say what you spending money on? And I think it is true, like, depending on the experience, it's like, if you give an individual maybe who's unhoused and going to Target, you're probably exposing their experience that not be pleasant, trying to get a gift card. Because there's stigma and racism. So I just like, I appreciate what you guys are doing. Like, it's like, yay. Because I'm like, I want to talk to you later because I'm like, everything you're saying is like what I'm trying to do too for my future research and just my career in harm reduction, especially with the Black community. Yeah.
Well, thank you so much, Jordana. That's wonderful. And I will now pass the baton to Marion, if you'd like to.
Yeah. So I have some questions here. You want me to just talk about the overall setting and what we do, and then save those questions for later, or you want to try to answer all that in one go? Or
I mean, it would be
either
great
one.
if you could leave some of those questions
Sure.
in the way
Okay.
you're talking about, but talking about them would be great.
Perfect. Okay. So yeah, I work managing, also providing direct services over at Magnet Clinic, which is inside of the Strut building. And Magnet, as it sort of like addressing stigma is built into the name. Magnet comes from, we are providing sexual health services to people living with HIV and people who are HIV negative under one roof. So it's a way of providing a status neutral clinic for HIV prevention and care and STI prevention and treatment. We also treat Hep C there as well. The majority of what we do is not long-term care. Is if someone is diagnosed, we can provide confirmatory testing for HIV. Then we get them started on meds and then link them somewhere else for long-term care. Same thing with like if someone walks in our doors and they are living with HIV but have fallen out of care, lost their insurance, have been off meds for any period of time. We can get them restarted on their meds and assist them with getting linked to care again. In terms of like, what is the substance use component of all of that? We do assess in our intake form for substance use, alcohol, and other substances, which really sometimes we address that in the visit and sometimes we don't. And I would say the majority of time, even though we're collecting that information, majority of the focus is on the reason that brought them in the door, which is they had some sort of STI concern or HIV prevention or care concern. But sometimes when that information can come in really handy in terms of assessing challenges with adherence, is sometimes pertaining to alcohol use or another substance, or occasionally people are very nervous about an experience, a sexual experience that they had where maybe they were using substances and then it lowered their inhibitions and they engaged in a sexual behavior that they would not otherwise. And so we are able to kind of, we talk about substance use kind of similar to STIs and HIV. It is a common human experience, and like that, just to give them information, kind of see what it is that they're seeking, right? Some people, assessing their level of change, if they're asking for like, hey, I'm looking for to get off the fentanyl, where can I go? Or like, then we can provide that sort of like information about accessing services, but we don't provide actually direct drug treatment or substance use treatment in our clinic. Unfortunately, I think that would be cool if we could, but it's one of the limits there. We do also provide harm reduction supplies, CFAR injection kits, naloxone, and people can get trained on how to use it, and, as well as fentanyl test strips. I would say at our magnet location is based in the Castro. A lot of the substance use that people report is alcohol, and stimulants, cocaine, methamphetamines, MDMA, Molly, ecstasy, and varying amounts and frequencies. Gosh, I'm blanking on the name. It'll come back to me later. But we also provide fentanyl testing strips, because the majority of folks, I would say, in that location are not intending on consuming fentanyl. So it's an overdose prevention. Our Sixth Street location, which I think is not so much the focus of what wanted me to talk about today, that is more people who are engaging in opioid use, fentanyl use intentionally. And so things like fentanyl strips are not, commonly needed there, but the majority of folks who come into our clinic are sexual and gender minorities, but we see everyone. So it is one of the first places that comes up when people Google, and so we definitely provide services to everyone, but we do have a focus on like sort of cultural ways that people use substances, like party and play. It's like a term that some people still use when using methamphetamines in the context of sex, for example. In terms of building trust and rapport among people who use substances, or especially around like stigma in substance use. I mean, I really liked what you said about like why people shouldn't trust me, or like that's something that you kind of earn. And people can, there's many layers to developing rapport or trust, but I think one of my favorite is shared decision making, or and in terms of like if I'm offering an intervention like PrEP, for example, we're talking about all the different options. Some people may be really skeptical. They've seen negative things on Facebook, or around how I don't, this is like all the side effects. I don't want to take something like that. And I can just like ask them, well, what are your health beliefs or concerns around what the side effects would look like? And you get to decide what you put in your body. These are just like the options, and my role is to just make sure everything is done safely and to give you information, and you get to choose what if you want to access this intervention or not. And it doesn't hurt to try. If you don't like it, you don't have to continue taking it. Kind of shared decision making, and assessing people's what their health beliefs are. I think that also kind of falls into the umbrella of like historical, engaging in like health institutions. There's been really like reasons why people would not trust medicine versus engaging in other kinds of substances from their friends, for example. I would say this is something that comes up a lot. There's like an added layer within like the trans community, because there's a lot of information sharing that happens at the community level, and people will trust their friend or Reddit a lot more than they trust a provider. And I think there's a reason for that. I think there's a lot of inconsistencies in what providers, have varying levels of like actually going into the details about like something like hormone therapy and really understanding it. Some people will just prescribe whatever someone asks them for. And what I do is I demonstrate my, where I get my information. It's available on the internet. You can look there too. Sort of like, I'm aware of the common like health beliefs around like hormones and and sometimes I'll kind of get ahead of that, like, oh, are you, afraid of, well, what do you want to get out of this? Like what do you want this to do for you? And then I will break it down and show them the mechanism of action for each hormone and like how it interacts with their body. In terms of reducing stigma, I think it's like kind of going back to that point of like, this is it sounds to me like you're maybe struggling with this and aren't necessarily comfortable with or maybe looking for some options, but also this is a common human experience, and there's other people that maybe like a group would be a good option for you, so you can kind of learn from other people in a safe place where you don't have to worry about someone looking up your medical record, like a family member. Those kinds of things come up where people don't want to disclose things in their chart. And so discussing like, this is how this information is shared or not, what is put in the chart. And we can just have a conversation about this and, we can provide you with information about where you can go next. But talking to other people in a safe setting, because you're not alone in this. A lot of other people may have a similar struggle, what you're describing to me. I think self-forgiveness is another concept that sometimes I will talk about if it seems appropriate, especially in the case where someone was using methamphetamines for the first time, they engage in behavior that they wouldn't otherwise, and had a positive immune HIV diagnosis. This is an example of, and I remember the thing that they said was, "This is a pretty big fuck up." Sorry about my language. That was a direct quote. And so then it was just kind of discussing, again, just have some room for, you're going to go through a lot of feelings, but, have some room for self-forgiveness. This happens to many people. You're not alone, again. Because I think that kind of, that feeling that you see, where someone's just like beating themselves up for making a quote unquote mistake, like, can get in the way of them engaging in care, can get in the way of them, if they, it's like a negative feedback loop that where they spiral out about making a mistake. Similarly, in terms of like developing trust, again, I think there are some folks who expect gatekeeping And again, this is kind of going back to like the trans folks. They are so many stories that people read about or hear about, like being denied care or access. And so they're you can just see the guard up before they even walk in the door, and then they expect to have a fight. I'm like, I'm gonna give you, this is just me getting to know you. This, there's no right or wrong answer to this question about like, tell me about your gender identity. I think there are some people who have read about like, oh, there's certain things that you're supposed to say in order to even get care. That is a historical fact of, how people were allowed to access services in the past. And so just letting people know, this is really just for me to like kind of get to know you and see like where you're at, where your thoughts are around this. And then it helps me to inform like how we talk about the options kind of thing. And you can just see people relax. When if you know that there's common like gatekeeping that happens in a certain intervention or kind of trying to address that at a time if you are getting that sense, I think is important. Yeah, and that I would say is one of the biggest challenges. I think in terms of accessing and reaching people. That's not very substance use related, but I think there can be overlap when engaging with people who are sexual or gender minorities. And yeah, and in terms of like how our agency like addresses like intersecting identities to address HIV and substance use. And prioritizing, being aware of disparities in, our geographic location, and really, making room for, for exceptions to things like the schedule, for folks who they made it in through the door that day. And if something's, it's like, oh, I'm sorry, we don't have any appointments left for the day, and you have to come back and wait outside in the morning. Folks may not come back, and there's a high likelihood there. So doing what you can with the resources that you have for that day in terms of staffing and whatnot, to try to either address it, right, get that person into the schedule, or, okay, I see that you made it in here today. We're somewhat limited, yada, yada. Can we make a plan? I want to make sure that you get what you are coming in for today. Like, can we make a plan that works for you and make that exception to fit them in somewhere else? I think letting people know, other common barriers like the cost, like our people do not have to have insurance if they walk in our doors, and have no insurance, and just letting people know, like, we can still get you access to your HIV medications. We can still get you access to PrEP. We can come up with a plan for you to figure out your hormone stuff, even if you don't have insurance. And because I think that some people just assume they're not going to be able to get those things if you don't explain to them. Because many other clinics, you would walk in the door, and as soon as you state like, I don't have insurance, and you're like, well, we can't see you then. That's the majority of my notes that I had made. Does anyone have questions?
Yeah.
Who wants to go first?
So I know that, you said you, 60, right? The harm reduction site?
Uh-huh.
And I know like they have that policy now where they don't give like the glass bubbles. Is that still going on?
I cannot comment on anything.
Okay. Okay,
It's a very highly political
Yeah.
environment right now.
yeah,
We have had to deal with people coming in and being very disruptive
oh, really? Wow.
and videotaping
Wow.
clients because of the very politically charged nature of harm reduction.
Yeah.
So that is, I mean, I'm half expecting it also for the hormone program, to be honest. Like there are a lot of people that are very much focused on this area to get rid of or to provide resistance against like DEI initiatives. I mean, there's very much a push for like at the DEA level to make barriers for people accessing testosterone for gender affirming processes. I'm seeing more rejections now with insurance companies in the PA processes. It all overlaps. Yeah. So yeah, I think they had to change the name from Harm Reduction Center because people were like, that is a bad thing. We shouldn't be whatever their political
Yeah.
belief is.
I know it's unfortunate. I know, some about it, but yeah, I appreciate you saying that because I feel like a lot of people don't know about it. And I didn't know it was that extent, like even where it's crossing over to other services.
Yeah.
I'm Jacqueline again, Jackie. I really liked what you were saying about how you approach people coming to the clinic with an inclusive, welcoming environment. I'm curious how you ensure that your staff are all trained on the same approach to making everyone feel welcome and included. Yeah, it's sort of what my research interest is in, and I really thought that San Francisco was sort of like a place that has all of the resources and learning, but it's not. So I'm just curious how your clinic approaches that, trauma-informed care and just language.
Well, providing opportunities for education on trauma-informed care. And I mean, I think principles of motivational interviewing don't necessarily impart all of like the information that you need for, but I think it's a good start too. I think leading also by example, like the way that we train people is through a shadowing model. Yeah, any opportunities that I can to get people out there to be aware, to get our staff to be involved in also the community of practice. Like, so HIV nursing is such a beautiful thing in San Francisco, and there's the getting the zero meetings that happen quarterly, just seeing everyone come together under one roof. And like, I see a lot of those kinds of those beliefs and those like pushes for like health justice talked about in those settings. And so encouraging staff and actually making time and space for people to attend those is 4 times a year. So as best as you can to meet and see examples of other clinicians in the area. I love AETC as a resource for continuing education as well, because I think they do a good balance of like talking about reducing stigma, talking about making welcoming environments for folks who may not engage in services, along with like the biomedical stuff, which everyone who's a nurse is kind of geeks out on that stuff.
Yeah.
But I think we just tend to attract very compassionate, empathetic people, and I guess we're lucky in that way. But yeah, that's a great question. How do you impart and how do you address it if you see that behavior that is not welcoming from a staff member? I'm still learning that too. So maybe you can tell me.
Well, you know, it all begins if they enter the door, or even like when they look at the building, right? And you mentioned just how there's like this historical piece that's so powerful, that we're still trying to dismantle, and that is just, you know, what services people can access. If there was a script, I mean, people had to develop a script of what to say to get access to care, then we're not doing our jobs.
Yeah.
So I challenge providers to be better. And so I'm curious just what people are doing.
Yeah, I mean, I think also, yeah, walking in the front door, being very intentional about the environment, and I mean, I think you can't. There's no one way, right? We have art shows on our second floor in our waiting room. There's one, and a lot of them are very sexually health themed, and you can imagine there's things like we do have like art shows that have like explicit like images of people's bodies in a positive way, right? And that might make other people uncomfortable to access services. Sometimes I will like prompt, like when we're engaging in with an organization where they were referring folks over for Hep C treatment, folks who are not necessarily sexual and gender minorities, where that they might not feel like comfortable in that setting. I'm just like, I make a joke about like, yeah, we might have pictures of penises on the walls, and that's what we do here, but rest assured you'll get excellent Hep C treatment. And then just making someone feel welcome, like in that setting. Well, yeah. But yeah, there will be people will have varying responses to any kind of intervention, I think. But also doing patient satisfaction surveys and actually doing something about them. And when you get feedback about what's working or what turns people off.
So you were talking earlier about that there are certain services that don't provide at Magnet. So maybe if you could talk a little bit about referrals and where you send people, and sort of related to Jackie's question, how do you make sure that where you're sending them is going to be as trauma informed and as supportive as you all are?
Well, okay, so I'm going to go back to one of my professors at SFSU in the public health theory class gave this assignment to me, gave an assignment to the class that was finding resources for vulnerable populations. And part of the assignment was get on a bus, go to the place, see what the waiting room looks like, how does someone engage in care, and she gave a very great story about coming up with a plan for someone who's at risk for intimate partner violence. When that plan needed to be in action, the person gets to the place and there was a waiting list for the shelter. And so, she used that example to be like, your resources, and you be able to describe like how to get there, what it's going to look like, what it will feel like, so you can kind of preemptively let people know what to prepare for. This is what I'm hearing the wait time is looking like. So just like get on it now, because you've got 3 months to kind of get in the door there, start the process now. It was a very impactful lesson for me, and so I try to keep a Rolodex of services. COVID really messed that up for me. Now I don't know what doing what. Still trying to figure out what people are doing these days. But yeah, knowing your resources, and again, these are soft referrals. It's not, we're not sending a fax somewhere. We don't really do that for, unless it's like linkage to HIV care that we do. But it's still like kind of giving a context. They're great clinicians over there. It's just like they're world renowned. Like we're really lucky here in San Francisco for, you know, you're gonna get really good care kind of thing. But that's what the importance of like communities of practice are. So like people who are engaging in substance use treatment they need to have get-togethers. They need to like, you know, talk about these things in a collective manner. That's so because then you're like, oh, okay. Then you get to know people who are doing the work in other areas.
Oh, thank you very much. I'm sure there are probably more questions, but we'll have to move on to our next panelist for now. And hopefully at the end, we'll have time to come back and ask Marion more questions. But thank you again. And I'd now like to invite Jonathan to talk a little bit about his work.
Hi, good afternoon, everybody. My name is Jonathan Butcher, and I'm here today. I want to share a little bit about utilizing a community advisory board for informing and decision making and guiding development research. And rather than me going to a lengthy soliloquy about myself and my personal lived experience, I'd like to have you kind of get to know me as we go through what I'd like to share with you. The community advisory board that I'm a part of is called Open Arms, and that means acronym time. Open Arms, everybody loves acronyms, stands for our personal experience is necessary. Addiction research means saving lives. And we just celebrated our 1-year anniversary. We're very excited to have it. Thank you. And let's see, we've come a long way, and I've been delighted to have been part of the process. It's been a very interesting year, to say the least. Our CAB originated from an idea, a plan rather, from Dr. Caravella McCuiston, who is seated here in the audience today, and also with Dr. Andy Tompkins, medical doctor. He is the director of Division on Substance Abuse and Addiction Medicine at General. They decided that they wanted to develop this CAB to kind of help, help the research that's going on right now regarding substance use. It can better reflect the needs of the clients that they serve. The mission for our CAB was developed professionals' input, along with community members, kind of as equal partners in the process from the beginning. The mission that we came up with is we are a group of individuals with lived experience in substance use and recovery who meet monthly to provide consultations for substance use researchers. We are problem solvers who provide a forum for frank and honest discussion relating to substance use and how research can help improve the lives of those who are using drugs. The kind of substance use research that we think could benefit from working with Open Arms would be, there's 5 of them here: peer recovery support services, researching the effectiveness of peer-driven mentoring, education, and so on and so forth. Community-based participatory research. Engaging community members in the research process ensures the studies are relevant and beneficial to specific communities that they serve. The opioid crisis interventions, developing and evaluating interventions to address the opioid crisis, including harm reduction strategies, medication-assisted treatment, and other recovery support programs. Continuing care models, investigating the efficiency of continuing care programs for individuals recovering substance use disorders focusing on long-term recovery management and support. And also, the last one is mental health and co-occurring disorders, studying the integration of mental health services with substance use treatment to address co-occurring psychological disorders and again, improve the patient's outcomes. Our CAB has done 4 consultations so far in this last year with researchers in various points in their studies. We've also worked with 4 additional research studies that we're going to be submitting, or I think they might have already submitted them and they're just waiting for it to be reviewed. This kind of community engaged research, it incorporates input from people who the research outcomes will impact, and again, as equal partners. I have always felt from day one that I had just as much that I could bring to the table as someone with a PhD in medicine could bring to the table. I never felt there was any looking down on anybody. It wasn't like that. It worked very well. When we say community advisory, there isn't one single, thank goodness, overarching community involved in research, and through community member involvement, we are able to bring a wide range and diverse voices needed for successful research. We hope that in the new year we're going to be able to, add even more diverse voices to, to our CAB. And let's see. There's an example of how it works. A few months ago, a researcher came in. She was doing a research regarding a marijuana research study. And for that particular consultation, myself being a regular pot smoker, I was able to give not only my lived experience, whoops, there goes my, okay, there's my notes. Excuse me one second here. Okay. I was able to give not only my lived experience, but also my present living experience. And that, at least for that particular study, was very beneficial to the researcher. I'm kind of a rarity in the substance use world. I'm an old drug addict. And we don't have many old drug addicts around anymore, unfortunately. I'm a 58-year-old man. I've used just about every recreational drug available except for fentanyl and Special K. The fentanyl, they can have it. I live on the corner of 6th Street and Mission, right smack in the middle of downtown, and a great big hotspot for fentanyl and speed and cream and just name it. It's all there as soon as I walk out of my building. I've lived there 16 years, seen it all. I empathize with substance users. I speak their language. I've been to prison. I've done the whole thing. And I don't consider myself what I used to consider myself when I was younger, which was I was a connoisseur of drugs, and I just drank and used without restraint. And what I've been able to do as I've gotten older is to, take stock of what's in my life, what's not working, and what is working. We'll keep that. That's kind of been my approach to life recently, anyway. But getting back to the CAB, let's see. I originally joined partially because of curiosity, and honestly, partially because there was money involved. Money is the great motivator. Nowadays, I think I'm wanting to be part of a process that can assist other people in getting off that existential hamster wheel that sometimes you get stuck on when you use. And I think so many people need a chance to live. They need gosh, life skills. Oh my gosh, life skills. Coming from the streets to an apartment, you don't know what to do, I'll tell you. So that's something I hope in the future that research can kind of, from a social services kind of lens, combine life skills and housing first and things like that as part of the whole picture of a better life. Let's see. Our CAB has stayed pretty much the same for the last year. We've had one or two people come and go. But for the most part, it's been the same. An example for me, at least for the last 15 years, haven't been homeless, knock on wood. We had a gentleman who was in our cab from the beginning. He lived on the streets. He still used Fenty, as he called it. And he was able to bring a voice to research into fentanyl and or xylazine or whatever the drug of the research was. And it was so interesting. I learned so much without having to go out and use xylazine or fentanyl myself. But it's things like that having a diverse group, which we have, we're able to kind of comment on a little bit of everything. I think in the future, I'd like to see kind of, like I said, a multi-tiered approach to substance use research, where other factors might play a part in improving somebody's life. So many of the people I see just hanging out on the street with a bubble in one hand and a foil in the other. They need something to do. That's a crappy hot hobby, I gotta say, to sit around high on Sixth and Mission. So I'm always a proponent for, more community involvement, more community performance involvement in art at the community level. That's just me. So anyway, Open Arms, we are always going to be there as part of the research process. And I want to thank you all for listening to what I had to say today. And I appreciate each and every one. Thank you.
Thank you. Appreciate you giving us that experience and a lot of skills that you dropped there. Does anybody have any questions?
I'll ask a question.
Yeah. You have to introduce yourself.
Oh, sorry, I'm Yvette. I'm from the School of Nursing. I work with Carolina. I'm curious whether you, in the CAB, you have an opportunity to sort of come up with your own research studies and like what you would want to study.
What would I personally want to study?
I mean, what do you think would be helpful or making people's lives better?
I'll tell you something. I was a dirty drunk for so long. And a simple little shot I get every single month called naltrexone has taken any triggering urge I might get for another drink to make it sound like it's a good idea, and it gets rid of it. If I go into a liquor store and I stay there too long, my nausea level starts kind of getting higher. But no, to answer the question, they told me for 25 years there's no magic pill for alcohol, blah blah blah. But this has been kind of that, and I joke about it, and I tell my friend, they could be shooting me with goat piss, but it's keeping me off of alcohol, so it hurts, and I don't know, more studies like that for medical, helping people get medical, like Suboxone is another thing. It gets you off opiates, and at least the times I've tried it, it got me pretty high, and it felt pretty good, but it kept me from wanting to go get, heroin or whatever else the opiate of the day was. So, and more medical stuff for curbing use, I guess.
Yes.
Hi, my name's Graham, he, him pronouns. I'm a researcher here at UCSF at the Centre for AIDS Prevention Studies upstairs. So when you're, as part of your CAB, when you're working with, folks doing research, what are some of the top things that come up, top tips or things to avoid, even from the start of when people are writing their research proposals, you think, oh, I wish that, they'd integrated that from the start, or
Sure.
yeah, some of the big things that come up for you all that you're advising.
Caravella, you might want to answer that question if you could.
Sure. So I think you probably have some things to add in. I would say very first and foremost, I think that was mentioned, is put in money, but allocate a budget to pay for community advisory boards or community members. In fact, any study that we consult with, we encourage them to put in a budget. We give the amount so that our community advisory board members get paid for their work. I think that we're super open to consult in any phase of the research study, from design, recruitment, etc. But our biggest thing is don't just come once if you can. Try to come throughout the duration of the study. Yeah. We've provided some pretty good feedback on where to recruit people, how to recruit people, how long people will sit for a survey, how to do qualitative interviews, where to disseminate findings is really important for us as well. But I think if you don't forget anything, if you forget everything we've said, I think make sure people get paid for their time is number one.
Okay.
Would you add anything?
Perfect, thank you.
I have a question. So for myself as a PhD student, and I'm starting a pilot study, should I go on this app as for the link and then to contact one of y'all to speak to you guys about my question, my interview guide, and is this appropriate? Am I doing the right thing? Am I in the right lane? Should I? That's how it will work.
Yeah, absolutely.
Okay.
Mm-hmm.
Okay, cool.
And I cannot help but say that Jonathan designed our logo too. So just want to give him a shout out. But yeah, anyone can consult with us just with the QR code.
We have a bunch of flyers here that we brought that have the QR code.
Yeah.
So I'll go ahead and leave them here for anybody that wants them.
Thanks.
Or we can pass them around.
One of the, go ahead.
Oh, I had a question. I'm really interested in, let's say a little bit more about art, and programming around giving people space to make art about their experience. I just heard that my ears perked up when you talked about art, because I think that is such a underutilized, powerful thing.
I'll tell you about the current daily substance users. They're nomadic. It's almost like there's moments where there's so many people using, so many dealers, so much chaos. You feel like you're at Burning Man or something. And it's this real nomadic kind of existence, which I think goes wonderfully with art and performance and that type of stuff, music, applied art, all that kind of stuff. I think our beloved mayor has really just kind of taken the situation and just kind of moved it over one street away from the Civic Center. And so like it or not, the only policing that's done in our area is we get a every couple of hours to wake up the people nodding out. But anyway, to get back to the whole Burning Man kind of thing, is I think it's a culture that if that culture is going to be around there, that culture combined with some of the other the LGBTQ culture, the people of color culture, all of that in this one area, I think it would be wild if Even if it helps get people off of stuff, a little tiny bit, I think it's a step in the right direction.
Just curious, so you do work with, just want to confirm, you work with PhD students who have no budget.
We do.
Okay.
So we're still up and running, and so all of our consultations are free right now. But we hope to, there's been some people, even in this room, who've written open arms already into budgets for future grants, but yeah, we'd be happy to help for no money, just your time now.
Oh, I didn't get to also mention that we, coming up in the new year, we're gonna be having like an expo, a big open house.
Yeah.
Where there will be swag available and all of us will be there probably talking. There might be a video presentation.
Yeah.
And of course, food. So, you know, when you scan the QR code, hopefully you get on a list and we can let you know when that happens, and all of your welcome, of course.
Thank you. Any other questions for Jonathan before we move on?
I'll hold mine until later, but yeah, go ahead.
Okay, great. Well, Tyrone, we'd like to invite you now to share some of your experience.
I'm going to start off by saying my voice isn't always my friend. So if you can't hear me, just give me a sign and I will happily repeat myself. Anyway, I'm Tyrone Clifford. I am the program manager of contingency management, one of the programs of contingency management at the Stonewall program. The demographic that my particular program serves are MSM and trans-identified folks, gender non-conforming individuals. We also do have another version of PROP, which supports everyone, no matter gender or how they identify. So our program, it's based in harm reduction. And we incentivize folks who come in, we incentivize our folks who are looking to make changes around stimulus, whatever that change may be. Sometimes people will say, I don't want to quit. I want to do what I like to do and make it to work on Monday morning with all my stuff intact, on time and with all my stuff. So we'll say, I have decided that this substance is causing me a big problem, but these things over here are not causing me a problem. I don't want to do anything about those. We can support folks with that goal as well. Okay, then sometimes someone will say, I can't do any of it. I need to stop. And we also have to support them with that goal. And the way we do this is through UA testing 3 days a week, every Monday, Wednesday, Friday. For every non-reactive, we try to stay away from positive, negative, clean, or dirty, because that's stigmatizing language. So the test is either reacting to the presence of the substance or it's not reacting to the presence of the substance. Our test will not tell me how much you've done or how long it's been. So it's like, I can't tell, you just did this a half an hour ago. It's not like that. It's either there or it's not there. And so for every non-reactive sample they submit, they earn these cash points that we issue with gift cards. It starts out small, $2 for the first test, and it goes up incrementally by a quarter per test. For every 3 non-reactive samples in a row, they get an extra $8 bonus. It's 12 weeks long, took 36 visits, and at the end of that, if someone has submitted all non-reactive UAs throughout the entire 12 weeks, they make $330. That say we're giving gift cards, but I would pay for anything that I can get a receipt for. It doesn't matter. I pay phone bills, I bought all kinds of stuff. One of my favorite places to go is Mr. S. There. And along with that, we do offer sort of a loosely structured group as part of the program. Because initially in its inception, it was just long hallway with chairs in the hall, horrible overhead fluorescent lighting. And it was just like an assembly line. Next. When the program moved to Stonewall, the option was given to be able to just make it what you want. And my director decided he wanted to make it more of a community space. And so with that, there's group support. The participants really do the heavy lifting when it comes to supporting one another, because I feel like we feel like the building community and getting that support from your community is, I think, it's much more valuable than having me sit back and tell you. And for most of the times too, a lot of the times, the other participants have much more updated knowledge as to what's going on than we would have. They'll know exactly who to talk to, exactly where to go, because they just utilize that service themselves. That really makes me feel good when I see them supporting them in that way. We do refer out to we refer folks to our more structured substance use program as part of the Stonewall Project. So someone may come in and say, I don't want counseling, but I want to do something. Then we're like the program for them. It's like a place for them to sort of dip their toe in the water and see what substance use treatment can be like. Without non-judgmental space, without feeling pressure to go into treatment. So on. And quite often, someone will say, like, after a couple of months, I think I want to get a counselor. And then we have them give Mr. Michael here a call and he gets them all set up. And vice versa. Like, we also refer folks to Magnet for STI testing. And our program has services within the STRAP building. We're not a part of Magnet, but there is counseling services available right there in the building. A participant can call up and say that, I want to just talk to someone today, and we'll find an available counselor for that person, and they can either do it off Zoom or in person, whatever is going to work best for the participant. I think that's been one of the big draws to the program is you can pretty much get service on demand. I'll let Michael talk more about that. Continuous management, back to that. Our focus isn't necessarily on getting anyone to do anything that they don't want to do. If someone comes in and tests and it's reactive, they'll look, am I out of the program? Do I lose my money? No, you don't. You've already earned that. I'm not going to take it away from you. We've given you 12 weeks, and it's up to you to decide how you want to utilize that 12 weeks. We'll help guide you, we'll offer you, information on what services are available and how we can help you better with the program, like what's working for you, what's not working for you about the program. They get a little bit of individual counseling time with myself or one of the other health educators in the program. That's part of the whole UA testing experience. We take them to the bathroom, they be in a cup. But I told them I'll have the results as fast as you can wash your hands. Then from there we go into private counseling where we tell them what the results are, whether or not they earn the institute that day or not. Then that's when we have that conversation as to what's working and what's not working. And sometimes they don't even want to talk about the results. They just want to talk about something totally, whatever they want to talk about. And that's totally fine with us. We also have an alumni program group that meets once a week. For folks who finish the program and just feel like I still, I don't necessarily need the testing anymore, but I still want that group support. And, and not feel like I have to be here every week. But that program is it's really taken off over the past few months. We have just about as many folks coming to that program as we do coming to the regular UA portion of the program. So yeah, that's pretty much the prop in a nutshell. Because I don't have to report numbers, so I see we don't really keep track of just how many folks have finished. But once a year we do a slight audit. We also refer folks out to other programs. Sometimes I'll have someone come into my program and says, I failed at abstinence. I failed at 12-step. And we're like, I can't do harm reduction. I have to do abstinence. And that's when we have the conversation as to to help them recognize that abstinence is harm reduction. Whatever you do to reduce the harm to yourself and others is harm reduction. He was the only white, they were saying like how the African Americans are not utilizing services. Well, it's, you know, when the authorities around you that look like you are telling you that this thing is no good for you, it is the problem, you're less likely to go.
Yeah.
And instead of saying, use management may not be working for you, you may need a higher level of care, targeted abstinence, you know, total abstinence, you know, but it's just, that doesn't work, it's no good, it is the problem. And that spreads, that's what they hear, and they don't want to hear anything else. Like, harm reduction is bad. It's not bad. I mean, what better way to stop harming yourself, banging your head against the wall than to just stop?
Yeah.
You know. Yeah, it's been a pretty popular program, so kind of like a 6-week waiting list, and then really, like the list gets that long, and that's not to feel bad. I don't like to have folks waiting that long. But yeah, that's prop. Any questions? Yes.
Can I ask questions?
Yes.
I guess like how can we change that like good and bad within the Black community when it comes to like harm reduction, like just opening up options? Like, 'cause I hear that with my interview sometimes where like it's like self like, you know, I messed up, now I can't do it, I ain't gonna do it completely, I'm gonna slip up and I ain't gonna try it. So like how do we change, like I don't know, like that's what I'm trying to figure out was like how can we make sure like with harm reduction, like let's just see what happens.
Yeah.
Let's try it out.
You know, we do that with a lot of that conversation a lot with clients too. It's like, you know, that person, it might be their first time in substance use treatment at all. They have no idea what to expect or how it may or may not work for them. So, you know, you had a use. Some folks go through this program without having a use at all, and some people do. And it doesn't mean you fail.
Yeah.
You know, like someone's like, well, I didn't succeed at that. Well, you succeeded when you showed up at the door. You walked in and asked for help. You may have not known what type of help you needed, but you knew you needed support and you came in for it. That is a success story to me.
We have to move on, right? Probably. Yeah, we've got about 20 minutes left. So, but you know, again, we might have some time at the very end to continue to ask questions and.
About business cards. Reach out and talk about this. I'll leave them out.
I just want to say something because, you know, I'm part of the core structure over here, which is what you said is radical in harm reduction, which I have heard probably less than 5 people over the last many years. I've been working this field to have said harm reduction includes abstinence. And that is, it's like, that's just, it feels like a dirty word in some circles. And so I just want to acknowledge you for saying that. And the other thing is like substance use, addiction, where it is a chronic situation. And it's what happens. It's what happens in diabetes. It's what happens in managing your blood pressure. It's what happens. It's like expect, like some people are going to hit hard spots, and then we're not here to make you feel bad, you know. But I just want to say that out loud. That's all I'll say. But go ahead.
Yeah. Thank you very much.
Yeah, I mean it's so not said. I've never heard it said. So yeah.
Make me blush.
Thank you, Tyrone. And now, Michael, that's about you.
Yeah.
You give up your senior experience.
Oh, certainly. So you guys all blew me away, and you made my talk time shorter because you've already shared all these great messages. So I guess what I thought I might do is just kind of tell you what I do each and every day. So I sort of feel like I'm really lucky because I get paid to love my fellow human and to just be there. And so I answer the phone a lot. I probably speak to 4 or 5 individuals a day who are making that really courageous step of asking for support. And all of them are at different stages of change. Some are ambivalent, some are court ordered, some are millionaires, some have nothing. And so each call, I try to remind myself that these are folks who are saying, hey, I need some help. And in the world that we live in, asking for help is viewed as a weakness. So I grew up here in the Bay Area, like I said earlier. I'm the oldest to 2 German immigrants. So I got to learn really early on to suppress all of my mental health issues and just, buck up. And so growing up that way, it kind of, I don't know, I've developed an appreciation that, no, I don't. I get to be a human and I get to respect other humans for being human too. And that's really cool. I really appreciate that. And I feel like I'm in my tribe here because I didn't realize you guys were fact-grade at harm reduction already. So this is really cool and it's reaffirming to me. So I don't know if this is going to be helpful or not, but I'm going to model a portion of a phone call with folks. So, like I said, a lot of people are calling because they've looked us up on a website or a friend said, hey, you should go check them out. Or this lovely individual has referred somebody who is ready for some kind of change. And so I generally describe what we do. We offer both individual and group therapy in a harm reduction environment. Tyrone spoke about the 3 treatment tracks that we support: abstinence, partial abstinence, and managed use. That we primarily, at least in the traditional Stonewall Project programming, support gay, bi, trans, and non-binary folks here in San Francisco who have sex with men. And then I say, yeah, you don't need insurance. I don't even need to see your ID. There's no cost. And so what I'm trying to do in that phone call is lower every single barrier so that, because I respect the fact that they are summoning tremendous courage. I mean, it takes a lot, right? First, you have to admit that there's something going on for you. Then you got to take the steps of figuring out who to talk to, and then you have to actually do that. And that can be hard for people. So outcomes of those calls are anything from ambivalence to totally breaking down. Wow, that they're just so worn out from actually doing the whole effort that now they have nothing left. And that's usually when I remind them that maybe they might want to give themselves a little pat on the back because it takes a lot. And I'll see higher engagement levels as a result of that kind of. So it's about dignity, respect, not using stigmatizing language. Just, for the most part, just listening and not judging or saying things like, well, maybe you should do X or Y or, that sort of kind of language, right? We don't want to go there. I'm kind of peeking over here at these questions because some of them I wouldn't know how to answer because I'm not a research person necessarily. But there are things on here that really excite me, and that is our group program. So we offer about 12 groups a week, Monday through Friday. Some are focused on folks who are seeking abstinence, partial abstinence, or managed use. We also have an art therapy group. We have groups that support different marginalized populations. So every Thursday night at Strut, we have a trans group that is probably our most well-attended group now. And the way we got there was we started sort of with our best outfit on, if you will, in that we each week offer a dinner, not just pizza, but like we've got really talented counselors. We always have at least 2 counselors in any group, but this group, because it's so large, we have 3, and they're very creative. And they do something I think is super important, is they ask the participants what they want out of the group. What do those components look like? Is it straight up sitting in a circle and having, you know, an open discussion, or is it just chatting over some food? Because it is a great unifier, right? Just like art therapy is. That's probably our third best. I don't want to tell you how many people we have in each group, but the art therapy group is usually attended by the same folks each week, because that really is freeing for them to make something. So we have art supplies. We offer incentives that we look at as things that are needed in the moment. So maybe someone needs a hygiene kit, or someone needs a sweatshirt, socks, #1 requested item, by the way. So we have all those things on here. And that seems to not only increase engagement, but continue. So, and then for us, I would say that word of mouth is probably the most powerful way to invite others who are in similar communities or similar networks to come join us. I'm a little anxious about tomorrow because we're going to introduce a BIPOC group in person. And we're going to use a similar formula. We're going to create food options for everybody. It is going to be led by folks of color. And I'm only anxious because I realize, especially in the BIPOC community, the stigma around asking for help, and the stigma of the idea of someone else knowing that you're asking for help. That feels like a real, I actually identify with that one a lot. I grew up in Vallejo, and just, yeah. I know that we always have to be tougher, have a tougher exterior somehow, in some weird way. And that for me is a problem I'd love to figure out how to solve. In the individual therapy area, we have a wait list too. Our wait list is probably about 2 months long, but what ends up happening is that you get a dedicated counselor. So you don't have to refresh your story with whoever is in the office that day. You get to set up a weekly schedule, just like regular therapy would be. And that's pretty powerful stuff too. A lot of folks request that. Again, we welcome all roles. So counselors could have a caseload of folks who are more focused on mental health and substance use. And that's okay, because again, we're going to welcome everybody. So I think I'm going to stop there and see if there are any questions at all. I did so well. There's no, I love that.
People come to the group if they are on the waiting list, not that they're going to.
Yes.
They're different, but
Yeah. So thank you. That's pretty cool, because if I have to wait 8 weeks to act on the decision that I have decided, we may not, 2 months from now, may not be in that space anymore. So I usually recommend, when folks contact me, is that I set up an initial individual session with a counselor so they can share what's going on for them, maybe learn more about what harm reduction means, maybe specifically all the various programs under the Stonewall Project umbrella, what those things can look like. So I make it more like a shop us type of a situation when I'm proposing the idea. And then, like Tyrone said, they have options. They can either do the session over Zoom, or they can do it in person. My personal preference is in person, because I believe that dialogue is more than just the words coming out of your mouth, on a 2-dimensional screen. But others might not feel comfortable coming into the Castro or coming into Soma, our other new location that just got licensed last Tuesday, finally. Only took us 11 months, but now we can see all of our clients there as well, which is awesome. And so during that initial session, part of the dialogue that the counselor is going to have with them is whatever their goals or desires might be, is that they'll then offer them which groups might lend themselves best to the journey that they'd like to take. So yeah.
Real quick question. Hi, my name is Laura. I'm a third year PhD student here in the School of Nursing. I also live in Vallejo.
Oh, right on.
Hey. So my research interest is really around infant feeding among people living with HIV, especially in light of the guideline changes with the CDC. And part of those guidelines changes, the wording is engaged in shared decision making, which is something that was kind of brought up by some of the panelists here. But how I understand shared decision making is more like kind of on an equity model, meaning I'm sharing space and equity with my provider. But I'm also kind of reading from you all here today that you're almost like switching that power dynamic into the person's space, but then also taking on the role of a facilitator and trying to like triangulate care and facilitate dialogue and conversation and self-understanding and awareness. So I was wondering if maybe I want to make sure first I'm on point, like with those kind of understandings, and then also, like if that's true, like how does that work for you? Like, how do you do that daily? If that makes sense.
All right, so I'm the non-clinical guy, so I'm going to try to maybe express this through what my philosophy is around that sort of thing. So we're all unique individuals. We're all in different places in our lives, tension points, happiness, all of these things. So I always sort of lend myself to believing that I know you're coming to me just with a support request, but you're in the driver's seat, and I want you to know that you're in the driver's seat. That no matter which road you take, where you turn, I'm still going to be there for you. Always. I just am. Until you are ready to take a new journey. And that's okay. So in terms of the facilitation piece, at least for the group environments for us, facilitators are there to prompt conversation, not to guide it, not to say, oh, today we're going to talk about X, Y, Z. It's more of a dialogue. And what I really love about groups is that I may not have exposure to a certain system or process or whatever. For sure, someone else in that group does. And so most of the time as facilitators, you sit back and you look at the other facilitator and you pick up body cues. And that's the extent of the role almost. There's also crisis management that occurs from time to time. Sometimes folks will excuse themselves, go to the bathroom and use. So there are times where the facilitator's role is a little bit different, right? But even in those moments, it's not about controlling how people feel or it's more about asking them to respect everybody else in the group. That kind of a tactic, if you will.
Come high, come low, come and shoot.
Yeah, that's a tagline for us, by the way.
In terms of like shared decision making, it's very much about power and also just kind of like you're figuring out roles in the situation. Like if someone asks me to prescribe something in a way that just seems really dangerous, that's a barrier for me. And my role is to provide you with information and to keep you safe, and also just see if I can help you make a decision about what's going to work for you in your life, and again, reducing barriers. So we can talk more about it if you want.
I'd love that.
Yeah.
Just a quick question. Moving upstream programmatically, how do you ensure that your counselors and staff are protecting their hearts? And you seem like dedicated providers of care.
So we have a network of supervision. So we have clinical supervisors and we have administrative supervisors. So let's just say that you're working with a client and they've shared something that triggers you, or there's transference, or all of those other like real human things. How do you let that out, right? Sometimes it's me falling onto the living room floor after I've gotten home and crying for 20 minutes. Sometimes. Sometimes it's talking to somebody who understands what I do for a living. and having them reframe, or at least let me see the reframe so that I can reconcile that and spend a little time healing my heart. One of the things that one of my directors told me once always sticks with me, and that is we lost a client to overdose, and I worked with that client for 2 years, and just in all kinds of circumstances, and they passed. And I was left with first the woulda, shoulda, couldas, which was really dangerous for me. And then I was sad. I was truly, truly sad. And they said to me, imagine what their life would be like if you weren't in it. And that changed my perspective a lot, because I realized that at the end of the day, that individual made their choices and they own those choices. And they may have come to a sooner end if I wasn't in life. So that's how I was helping my heart stay whole, or as whole as it can, I guess. Yeah. Yeah.
I'm worried that we're getting near 5 and people might start getting up and leaving. So I wanted, if it's okay with you, Jenny, to hop in. I just wanted to say thank you to everyone. I just want to acknowledge your expertise in what you shared, and it's really critical for us to hear about these things when we're doing research. And you can get that many of us are clinicians, we're nurses, not all of us. We're psychologists. Right? And so just the things that you shared are really important. And I'm just really honored that we came all this way here. And I do want to say out loud that I know that we talked to you, speaking of money or incentive, and we don't have that today. And that is on my disorganization, and we will follow up with you, because I think it was discussed with everybody as an honorarium. And so I just want to say that out loud, and I'm not prepared. And I beg your forgiveness, and I will follow up with you by tomorrow. So we'll reach out to you in some way. Are there any another time, Jonathan, I'll talk to you about like how do we keep people busy? Because that's one of my fascinating areas, because I think that too needs something to do. Thank you.